Hi, everyone, and welcome to the Arthritis National Research Foundation's Researcher Spotlight webinar series. I'm Emily Storman, the CEO of ANRF, and on behalf of our Board of Directors, Scientific Advisory Board, and staff, I'd like to welcome you to the Spotlight on Rheumatoid Arthritis. We're excited to have so many of you joining us from all around the world. We'd like to also recognize and thank each of our corporate partners for supporting our Research Spotlight series. Special thank you to AbbVie for being a gold level sponsor for your continued partnership and dedication. It's because of our partnerships we're able to continue to pave the way for new innovations and learnings from our researchers, so thank you. Before we get started, there are a couple of logistical pieces of information we want to share. First, the webinar is being recorded and we'll have it available on our website and YouTube channel in the coming weeks. Second, if you have questions, please type them into the Q&A. If we aren't able to get to yours, please email info@curearthritis.org after the webinar with your question. Now, I'm honored to turn the mic over to our patient moderator for today's session, Danielle Bryant, to tell us about her story of living with rheumatoid arthritis.
Thank you so much, Emily. I am very honored to be here and be chosen to be the moderator for today's incredible discussion with two amazing researchers and doctors. So as Emily just said, I am living with rheumatoid arthritis. I am 49 young years old. So to tell you about my journey, it all started when I was an athlete in high school. You know, there I was playing catcher in softball and playing basketball. And I started to feel so much pain throughout all the joints in my body, specifically my feet, my knees, my hands, and my elbows. But as a devoted athlete, I thought it was just part of the game. I was literally playing sports, you know, like a full-time job as an adult, 40 hours a week. I was also running camps on the weekends. We played in a state tournament my sophomore year of high school. And this was a really big game because as a 16-year-old female, all you can think about is winning this state championship game. Well, we lost. And when we went into the state tournament, we were 40-1. So this loss was so big for us. So we took a 2.5-hour drive home on a bus and all crying, right? I mean, if you were a woman listening to this, you know what I'm talking about as a 16-year-old student. So that is when it compounded. The next morning I woke up and I couldn't move my legs out of bed. It was one of those moments where you're like screaming for your father to come and help you because you didn't know what was happening. And the disease really took over. So I think all of the pain that I was experiencing from what I thought was hard work was now compounding throughout my body. And lo and behold, it took several doctors for me to be diagnosed with rheumatoid arthritis. The one doctor who actually did was a podiatrist, because at that point I was on walking canes and I just wanted to be able to put pressure on my feet. Well, he asked me if anybody had ever tested me for rheumatoid arthritis. And I said, I don't even know what that is. And so he did a blood test. He actually donated the blood test to me because I didn't have health insurance at the time. Later that night, I went to the library. Yeah, it used to be a building where we'd go look at all these encyclopedias. And I turned to rheumatoid arthritis. And there I found the photos that you can find where your body is folding itself inside out, right? My life took a very wild ride all through my 20s and 30s. And then finally in my 40s, after fighting for myself over and over to get the right medication, I found something that worked for me. And since then, now I've completely changed my life. I go to the gym every single day, and I believe in movement. Movement being the medicine that has changed my life, along with all of the science and research that Arthritis National Research Foundation has done with these incredible doctors you're going to hear from today. And so I then also committed my life to share my story with you all. I run a platform called the Make It Count for Danny Foundation, where I send movement packages all over the world to help people to keep moving. Movement has changed my life, and I want it to change other people's lives. I really believe that although my joints are failing, as long as I keep my muscles strong around my failing joints, I will get a better life, as well as having these guys, science and research, developing better medications and better ways of a quality of life. So that's why I'm here. I'm here to just be so happy that I was diagnosed with RA and that now I have found the best solution for me, which is a combination of modern day medicine, training, diet, rest. It all matters. And today we're going to hear from some amazing doctors, right? And the first one we're going to hear from is Dr. Christian Lood. And so I'm going to introduce him to you guys, and then he will take over. So Dr. Christian Lood received his PhD in biomedicine at Lund University in Sweden in 2012, studying the role of innate immunity in the immunopathogenesis of SLE. Following a brief postdoctoral training in cardiovascular disease, he joined Professor Keith Elkin at University of Washington in Seattle in 2013 as a visiting scientist. Dr. Lood is currently an associate professor of medicine, and Herdan and Esther Mari Endowed Professor of Rheumatoid Arthritis within the Division of Rheumatology at the University of Washington, where he leads a team of 10 members working to improve the care and quality of life for individuals with inflammatory rheumatic diseases. Dr. Lood received an ANRF grant in 2019 in order to research mitochondrial mediated inflammation and autoimmunity in rheumatoid arthritis. All right, Dr. Lood, now it's your time.
Thank you, kind of Danielle, for that wonderful introduction and for the segue we're going to take from here. And thank you also to ANRF for setting this seminar up and for inviting me to share some of our ongoing work on mitochondria. And similar to what Danielle was highlighting, we're going to talk about movement and the importance of movement, and in this particular way, how mitochondria move and may transfer damage throughout the cell. So for those of you who may not be familiar with mitochondria, these are what we usually call power plants of our cells. So they're structures within your cells that provide energy, just like a power plant. But similarly also to a power plant, this comes with some caveats. And mitochondria, if not cared for in a good way, may also be inflammatory, and they may also promote autoimmunity. And this is primarily related to lupus, another rheumatic disease, where we find that patients develop antibodies towards mitochondria, including one that we call cardiolipin, which is related to lupus or related to cardiovascular disease. My group has also demonstrated that this is also commonly seen in patients with rheumatic disease or rheumatoid arthritis, where they have antibodies targeting mitochondria. And this is actually has prognostic abilities to identify patients that are going to have a much more severe disease progression. But what I wanted to talk today about is more so the role of mitochondria in mediating inflammation. And we will be focusing on a particular peptide from mitochondria called N-formyl methionine peptides. This is a small mitochondrial peptide that is highly inflammatory. But when would it be then that a mitochondria, this structure inside of a cell, would ever see our immune system? Well, during the last decade or so, we and others have shown that mitochondria are maybe not as static as we first thought, but they're actually moving. So nowadays we think about a mitochondria as this chargeable battery, if you would. You could bring it into the kitchen and use it in your mixer, and then you can take that battery out again and move it out in the yard, if you would, for one of your power tools. So mitochondria can go and transfer to wherever they are needed, boosting energy in immune cells. So what we and others have demonstrated is that some immune cells and even some platelets, they have this capacity to release mitochondria into the extracellular space where they now may expose these mitochondrial peptides that are inflammatory. So do we then have evidence that this is happening in arthritis, or is this just happening in the lab? Well, here I'm showing you a picture from a friend of mine up in Quebec, Eric Bouillard, and he demonstrated that in the synovial fluid, in the joint fluid, there are some mitochondria spinning around. And we took a different approach to try to demonstrate the same thing. We measured these mitochondrial peptides in the blood from patients with rheumatoid arthritis, either here in the blood or plasma or in the synovial fluid. And we found indeed that patients with rheumatoid arthritis have elevated levels of these mitochondrial components in the blood, and that corresponds to active disease. So to summarize this first part, we have now demonstrated that in the blood of patients with rheumatoid arthritis, they have these power plants circulating, spitting out these damaging toxic components. So the question we then asked is, if we now have these power plants, these mitochondria in the bloodstream, do they do anything? Do they participate in disease progression? And so what we know is happening with these mitochondrial peptides is that they are recognized by some of our immune cells, in particular neutrophils, that is the main interest of my research group. And they can activate a particular sensor called FPR1 and drive inflammation. So then the question may be, what is a neutrophil? And neutrophils are fascinating, wonderful cells to study. They are the main white blood cell we have in circulation. 60 or 70% of your white blood cells are going to be neutrophils. They are essential to protect ourselves against any infectious agents, whether it's bacteria or virus or fungi. They're just wonderful cells. Without them, we would die very briefly. So they act very quickly as soon as they see any pathogen. They can eat them, destroy them. So they're essential for our host defense. However, not only are neutrophils participating in our host defense, but they're also very important in many inflammatory diseases, promoting disease. And that's always the issue with the immune system, that there needs to be a balance. So in rheumatoid arthritis, we know that neutrophils do a lot of mischief. And one of those things is that they infiltrate, they go into the joints of the patient and they become activated. And then they start spitting out damaging components, destroying the cartilage, causing cartilage destruction and bone erosion. So since we now know that neutrophils are very important for developing rheumatoid arthritis, we then asked whether these mitochondrial components could participate in that neutrophil activation. So we set up a system looking at this, where we took neutrophils from a healthy individual, and then we added these mitochondrial peptides, or FMETs, to them. And we found that this activates a neutrophil. It makes them more sticky. It makes them more activated, inflammatory. And we can measure that in the lab by looking at this particular marker, CD66B. So we then asked, does this happen with the blood from patients with rheumatoid arthritis as well? So to investigate that, we took neutrophils from healthy individuals and we let them swim, if you would, with this blood from patients with rheumatoid arthritis. And we found that there are components in the blood, in the circulation of patients with rheumatoid arthritis, that just massively activate neutrophils. They become super sticky and inflammatory. So there's something in the blood of patients with rheumatoid arthritis that neutrophils react quickly on. So then we asked, could it be that whatever is causing this neutrophil activation is driven by these mitochondrial components? So to investigate that, we blocked this receptor, this sensor for mitochondrial peptides. And we found, doing so, we found that we could reduce neutrophil activation by about 30% or so. So it's not everything, but it seems, at least in this setting, that mitochondrial peptides do contribute to driving inflammation in rheumatoid arthritis. This is, however, only in the lab setting. It is always hard to make a conclusion based on this. And the next step, usually when trying to identify new therapeutic targets or so, is to move into a mouse model or an animal model. And so that's what we did. So here we are asking the question whether this sensing of mitochondrial peptides is important in driving inflammatory arthritis. Here we're using a mouse model of serum transfer arthritis, where we can transfer disease from one mouse to another. On the y-axis, we're looking at inflammation, and on the x-axis, we're looking at time. And so it takes about 7 days or so for these mice to reach their maximum disease, and then they usually recover after that. In blue, we have this regular healthy mice that we have now infected or given disease, and they developed an arthritis over the span of 7 days. And in the green, we have these mice lacking sensing of mitochondrial peptides, and we see that though they're not protected against arthritis, at least they have a reduced inflammation, again by about 25–30%, consistent with our lab findings. So it seems, at least for now, that these mitochondrial peptides that are present in the blood of patients with rheumatoid arthritis can activate neutrophils and cause inflammation. And we do believe, based on the data that we have and others that I couldn't show today, that targeting this receptor FPR1 on neutrophils may be a new molecule to consider when thinking about new drug targets that could be relevant in arthritis as well as in other inflammatory conditions. And then finally, thinking about these blood-based markers that also Danielle was talking about for diagnosis and prognosis, neutrophils spit out a lot of things when they become activated. And one of the markers they release is calprotectin. So we asked, is there any benefit to measure markers of neutrophil activation in patients with rheumatoid arthritis? Does that improve on diagnosis or prognosis? So back in 2020, we made this initial observation of looking at levels of neutrophil activation, calprotectin, also called S100A8A9, and we measured that molecule in 3 different cohorts of patients with rheumatoid arthritis as well as healthy controls. And we found elevated levels of calprotectin in all patients with rheumatoid arthritis, in particular then in patients with active disease. So it was able to monitor fairly well disease activity as measured by CDAI. And this is great. We had a new marker here that could track well with disease activity. However, in the larger picture, this doesn't add anything. Both the provider and the patient already know that we have an active disease. Us measuring a molecule and saying that, yes, this one is also elevated, doesn't really help. We want to do something or provide some information that the provider and the patient couldn't know. We want to predict the future. That is where the strength of a biomarker lies. So to do that, we had access to a patient cohort of about 300 patients with rheumatoid arthritis. And this was an inception cohort, meaning that this was the first time they went to the rheumatologist. So very early on in their disease onset. And then we had followed them for 8 years over time. So the question we asked was, if we now take a blood sample from this patient, the first time they go and see the rheumatologist, can we then predict what's going to happen with this patient, whether they will do well or whether they will do poor in their disease? And that's exactly what we found. We found that, again, measuring this marker of neutrophil activation, calprotectin, we could identify clearly those patients that had a much more severe disease progression, developing this erosive joint damage. And this added clinical value because other current biomarkers of disease progression were not as good or could be complementary to the one that we found. So it had clinical utility. Another important aspect thinking about biomarkers and predicting responses, if you would, is that currently we have lots of really good options to treat rheumatoid arthritis, but they don't all work for the same one and the same patient. Often only 60% or so of patients will respond well to a treatment. And so it's important to identify early on those patients that will benefit from a treatment and those who will not, so that we can better provide a good treatment for each and every one of our patients. And this is something that Dr. Perlman will talk about in a little bit as well, a topic that we call personalized medicine. And so we studied this using 2 different clinical trials looking at one drug that targets JAK-STAT pathway, so a signaling cascade, and one that targets more so the adaptive immunity, the T cell, B cell interactions. And we found in those patients at baseline, before they got their drug, that those patients that had neutrophil activation, including markers of calprotectin that we just discussed, they responded very well to these drugs. However, if you didn't have neutrophil activation, if you didn't have elevated levels of calprotectin, then you didn't respond well to these drugs and would likely have benefited more by another treatment. So we think these markers here of neutrophil activation, together with others, may be a starting point to move towards this field of personalized medicine, where we're able to more personalize our treatment and provide the best possible drug to each and every individual. So to summarize this last part of my presentation, I hope I've convinced you too that neutrophils release things, including calprotectin, and we can measure these markers, and they may have clinical utility in guiding treatment, as well as guiding, giving information about disease progress, and thus being able to intervene early on to prevent disabling disease. So to summarize, I hope I've convinced you that in rheumatoid arthritis, mitochondria are not static, and neither should we be, but they are on the go. They are released by cells, and we can find them in circulation as well as in the joint tissue and solution. And we can use these markers of mitochondrial activation and neutrophil activation to help monitor disease activity, assess prognosis, and guide treatment. And finally, we believe that targeting these processes of neutrophil activation as well as mitochondrial movement may help alleviate disease in rheumatoid arthritis. With that, I would like to, of course, acknowledge all my collaborators and colleagues that have been involved in all of these studies, both locally at University of Washington as well as nationally and globally. And not least, I would, of course, like to thank ANRF for their support throughout the years for these studies. ANRF was the first foundation to sponsor me as an immigrant PhD researcher here in the US, and to allow for us to start this group, start my group and start investigating inflammatory causes or regulation of inflammation in arthritis. So I'm very grateful for that. And thank you all of you for attending this seminar, and I'm happy to take any questions after Dr. Perlman's discussion.
Well, all right. Dr. Lood, thank you so much for that. Mitochondrial movement. I love that. So as he mentioned, we have Dr. Perlman next. So I'm going to introduce him here. I also want to remind people that if you have any questions at all, please list them in the text box that's been provided on your Zoom link. So let's see, Dr. Perlman, over the last 20 years, Dr. Perlman's area of interest has centered on rheumatic disease. His laboratory focuses on two facets of rheumatology: the role of comorbidities in rheumatoid arthritis, including atherosclerosis and obesity, and the role that macrophage heterogeneity in the target organs, such as synovium, kidney, and lung, plays in the pathogenesis and remission of RA, systemic lupus, erythematosus, and systemic sclerosis. Dr. Perlman received an ANRF grant in 2002 to study cell cycle regulation of cytokine and MMP production. He currently sits on the ANRF board of directors. Dr. Perlman, now it's your time to shine.
Thank you so much for the introduction. Thank you for inviting me for the speaker for this wonderful webinar here. So, rheumatoid arthritis, as Danny really discussed, is a very complex and debilitating disease. And if we think about it in a longitudinal setting here, we have patients who will be healthy, of course, and then we'll start to develop some preclinical systems and different characteristics of RA. And eventually they will transition and start to develop more comorbidities or morbidities associated with RA, and eventually establish RA. The great thing that we want to do right nowadays is try to understand, one, who are the patients that are going to transition from preclinical RA to early RA, and how we can treat them better. And I think one of the studies that have been shown is that the earlier we treat patients, the better prognosis and the better response rate. So in this slide, really what I want them to pay attention to are all the words that are in red or pink, really. And these are all the new therapeutics that exist for patients with RA. So you think about it, I started my research in 1998. In 1999, the first TNF inhibitor came out, and that transformed our field into an amazing area. Since then, we've now have anti-TNF therapies. We have anti-IL-6 therapies. We have anti-B cell therapies, anti-T cell therapies. We have JAK inhibitors. There is now numerous other types of therapeutics that are going out there, a lot of antibody-associated therapeutics and small molecules that are ready to treat RA. However, if you look at all the clinical trials associated with these approved therapeutics, they all show a similar response rate. And the issue becomes is, which one is for the right person? Who gets which drug? And we waste about $3 billion a year on trial and error for these therapeutics. So really, there is no rhyme or reason why we treat one patient with one drug versus the other. It's all trial and error. So I love to think that we are the smartest people in the world and we are so intelligent. However, what we do is we actually learn from our colleagues. And what do we learn? One of the best colleagues we think about is oncology. And in oncology, what do? They go to the tumor. They go to where the cancer is. They say, okay, what's happening in the actual place where the disease is taking place? So what they would do is they would do a biopsy of the tumor. In this case, they would take a piece of the tumor out and try to examine it. And I think that is something which we usually don't do in rheumatology. In rheumatology, what do we say? Let's look at blood and hopefully say blood will be some type of surrogate what's occurring in your joints. Well, that's not always so true. So we want to understand what's happening inside patients' joints. What is going on there that can tell us how to treat a patient and maybe which therapy is the right one for them. So nowadays, if you take a biopsy of a patient, you can do many different types of analyses. Everyone's used to analyses where you get some histology, some pictures. They take a look at the tissue and they say, oh, this is very inflamed. This is not inflamed. But nowadays, with development of new technologies, we can now understand many different aspects from that little piece of tissue, not just saying, is it inflamed or not? I can tell you which cells are there, what types of cells are there, what are the cells producing, what are the genes that are being expressed, what are their friends, which cells are next to the other cell, and how do they interact? There's so many different aspects that we can now understand at the biopsy level that tell us what's happening in the disease. So we think about it as a disease deconstruction. And then once we have all that information, we reconstruct the disease to try to understand which therapeutics might be better for one patient than another. So at around, let's see, about 2015, when I became the chief of rheumatology, we decided that we need to adopt this type of thinking, go to the tissue. Our European colleagues have been very advanced in this. They've used ultrasound technology, which we constantly use in our division of rheumatology, to understand how much swelling a person has. We also use it for injections. So in order to give steroid injections, what they've done in Europe is they've used this to say, okay, I'm going to use ultrasound to understand how I can get into the joint and take a quick biopsy. This is done in an inpatient, in a office visit. It's in an office setting. You just get a little shot of lidocaine, just like you would get for a tooth extraction. So no difference in that. You are fully aware of everything. It is about a 20-minute procedure, and it's and you go out the same day, really about an hour later. We've done already in our group at Northwestern, we lead the country in this. We've done about 150 ultrasound-guided synovial biopsies on patients with RA, and almost everyone has said the procedure is outstanding. We've had 90% of patients who say they'll do it again. So we're very comfortable with this procedure. And what we've seen is a lot of patients are willing to do this because of their willingness to want to help our ability to learn about patients' disease. They want to be able to help us with precision medicine. They want to be able to change the paradigm that exists in rheumatology in order for everyone else to benefit. This altruistic behavior is something really impressive about patients with rheumatoid arthritis. So we did this experiment initially where we got patient cells and we got the tissue. And we said, okay, we're going to take the tissue and try to find out what are the genes that are being expressed. So in this case, we took tissue from patients with osteoarthritis from their joints. So these are patients who had joint replacements. We took our biopsies from rheumatoid arthritis of patients, and we took all those tissues, we grounded it up after, in liquid nitrogen, we extracted the genes from there. And we said, okay, what's going on here? What do they express? Are they different? What we noticed was they didn't form a pattern. So what you see in this type of slide is looking at, you would expect that all the blue patients, again, the OA patients would be on one side, and all the red patients would be on the other, rheumatoid arthritis. They're two different diseases. But when you take all the cells together, you're not seeing those differences. And I always think about it as this way. A vegetable soup. Your tissue, I compare it to a vegetable soup. If you taste the soup together like this, it's all going to taste the same. It's not going to be so different because really what makes up the soup most is the liquid and maybe the spices you put in. But if we try to understand the individual components of the soup, so how much cabbage did you put in, how many carrots, how much pepper, if we can try to understand how you do that, then maybe we can really understand the disease. And that's what we can do nowadays. So what we can do is, our ability is now to take that tissue and separate all those individual cells. And now separate all the cells, so our pepper cells, our green pepper, our red pepper. So we can separate them into individual groups. So this is a perfect example. This is 20 patients that we've taken their tissue from, and we're able to separate every individual cell on that patient's tissue. And then we combine all those cells together and find out, look, all the T cells. So again, I look at all the carrots, all your T cells form one big group. All of your myeloid cells, these are your neutrophils, your monocytes, your macrophages, form a group. Here are your B cells forming a group. So every one of your components now, I can break down. Instead of doing a whole big tissue, I can break down all the components. What's even more impressive now we can do is that I can take these components and break these down even more to find out, wait a minute, maybe use different types of tomatoes, maybe use different types of carrots, that all these different cells are not just one big group, but a bunch of little independent populations that exist in your tissue. And together, they work in concert to help cause the disease. And one of the best examples is here, this study, what we did. We said, okay, we're going to look at one population called macrophages. Macrophages are known to be the garbage disposal of your body. They eat everything. What they've also known to be is that they're the first cell type that's ever been shown that there's number of cells in the tissue before you have therapy and after you have therapy correspond to response. So if you see less of these cells of this total population, these patients all responded. However, that's very hard because macrophages, like I said, are multiple different little components. There are many types of macrophages, macrophage A, B, C, and D. In this case, we identified 14 different macrophage populations. So these are brothers, sisters, cousins. They're all very similar, these macrophages, but they all have a separate purpose. And what we noticed was, we saw that if you had this population say cluster 5 or cluster 10, you responded to therapy. Wow. Now we can go and look at a patient, do a biopsy, look at their cells individually, and see if they have population 5 or population 10, they may respond to therapy. That's precision medicine. No more giving, let's try X, Y, and Z. Let's try it that way. We now may have the ability to actually say, okay, let's do a bigger trial. Let's test these people with anti-IL-6 therapy, with a JAK inhibitor, if those affect each individual population. And I think this slide sums up what's really happening here. So here in our world right now, here's our current situation. We have patients with either early RA, maybe established RA, patients who haven't been treated yet, and patients that have already been treated but failed the type of therapy. Again, 40 to 60% of patients fail initial therapy. So what do we do for them? So we try this initial therapy. Some patients respond, some patients don't. What do we do? And we keep trying and trying and trying. Well, let's think about it a little differently now. Say we can now find out we have 3 different patients here, but we did our biopsy at this point in time. We know what's the cells and the genes that are expressed in each cell happening. And now we say, wait a minute here. If you have this population of cells that expresses these genes, you're going to be more responsive to this drug, and so on and so forth. Right now, we have 28 patients already enrolled in our trial. Our goal was initially to get 100, but COVID came and hurt us a little bit. But again, we're still growing, we're still expanding. And I think this is the first time you actually can see a study where you can take the patient cells that's going on at that exact tissue and saying, here's what happens at time A before we treated them. And then we're going to look later on and see if they responded. And if they respond, now we can actually say, let's do this predictive power. That's the key. Can we predict it? So truly what I believe nowadays is the future precision medicine. It's now. It actually can be for now. And I think it has that potential. A couple of years ago, I didn't think so. Now with the ability of technology and just thinking about what we can do in these studies, just to give you an example, these studies would have taken me months, years, these experiments to do. I have a robot that can do it in 24 hours. And then we use our AI abilities, and now we can do that quicker. So our analysis is much faster. Our ability to do these, to actually extract those cells and the genetic information is much faster. So this is something which is really technologically conceivable now. And that's why we're so excited about it. So thank you. And I want to thank, of course, my collaborators, but really all the different funding sources. And like I said initially, Arthritis National Research Foundation was my first award that was given when I had my initial K award, which is a mentor award. And as a chief, I'm very focused on making sure that we have that next generation of rheumatologists. And what's really clear has been shown here, patients who have, individuals that have a mentored K award. So this is an award that helps start their career by NIH. If they don't have a second award, like from the Arthritis National Research Foundation, those are just so crucial. Without that award, their chances of succeeding are almost down by 70%. That's how important this type of award is for individuals. If somebody has these type of Arthritis National Research Foundation awards, it can really transform their career and allow them to take that next step and truly be that independent scientist.
And we love that. Thank you so much, Dr. Perlman, for all of that information. Macrophage, soup. I got a lot of macrophage. So listen, guys, we just got a whole bunch of information dropped in by these 2 amazing doctors. So if you have any questions, can you please write them in the dialogue box there? Let's see. So, all right. Dr. Lood, should one be concerned about how neutrophils in a blood draw, how can they approach their doctor for more information?
Right. So I would say this would be again a question for your provider to answer when it comes to clinical kind of harm, if you would. But just as a general kind of principle, many of the drugs that you will be given, including prednisone, for instance, could increase your neutrophil count, and some drugs will decrease them. And of course, when it comes to decreasing immune cells in general, they could come with a risk for infectious diseases and all of that. And that's a kind of backdrop with many of the immunosuppressive treatments we take or give in general to control disease. But this would be, in general, I would say, talk to your provider about that if you have any concerns about certain blood values. But in general, medicines do change blood levels or blood cell levels.
All right, thank you for that. Okay, so this question is for the both of you, Dr. Perlman, Dr. Lood. When might RA patients have access to the test that both of you guys have discussed?
Yeah, Dr. I'll let you go.
Excellent. So the one that I primarily discussed would be calprotectin, and there are other ones as well. We work closely with many of these kind of diagnostic companies. I'm not going to mention any names here, trying to get some of these assays out. Because it's hard for an academic to start building up a company, and you often work as a community. But when it comes to calprotectin, we're actually already using it. And many clinicians, when it comes to inflammatory bowel disease and so forth, where they measure this component in the poop. And more clinical laboratories are starting to measure this marker also in the blood. So it's up and coming, but we're not quite there yet that we're using it on a standard basis. I think we just need more data and help kind of get the message out there that this is a wonderful, good marker.
Yeah, I agree. It's amazing what we can do now. For the synovial biopsies, we've now in Northwestern, we have trained over, I think it's 27 different individuals at 30-something institutions. So some have left and gone to other institutions. We are one of the major sites to train people for ultrasound-guided synovial biopsies. And moreover, the people that we've trained now have started a special course to even expand this. So on different coasts to make sure that it's easy, more accessible for people to have these biopsies. So again, I think anywhere on the coast that you are or central United States, there are groups that can do these biopsies. And again, this biopsy is still not yet shown. These biopsies, we don't have the ability to say, yes, this is going to happen. Data suggest all these things. Our data are statistically informative for this. But again, it's not something that's been FDA approved. The idea is to build up our patient numbers. The idea is to eventually go to the FDA and saying, here, we now have 200 patients. This is what we've shown in our study. So I think this is something to be very exciting.
And just, if you don't mind, just quickly jumping on that question, and this is really where many of you can help as well as patients. When asked to participate in research, please take the opportunity and help people like myself and Dr. Perlman to give some blood or tissue if you have availability. And that really helps further the research almost as much as the funding does. Your participation is much appreciated.
Yeah. Yeah, I agree. And Pete, I said, we've seen patients who are extremely altruistic and really just want to help us and help themselves and help their colleagues and their friends with rheumatoid arthritis. And the best way is to participate in a trial, in a study.
That's definitely me. Like, I would love to participate, and I'd love to find out more information about to participate in any type of study that you guys have. So you obviously have my contact information at this point.
Okay.
So, hey, Dr. Perlman, what are potential interactions between RA and other health issues?
Yeah, unfortunately, RA has a lot of comorbidities associated. What that means is other diseases. So patients with rheumatoid arthritis have a higher incidence of atherosclerosis. So that's used to be, one of the things that actually reduce mortality is the atherosclerosis. And it's atherosclerosis not that we normally think about. So when you think about, heart disease and atherosclerosis, you kind of think of high cholesterol and all this, plaque buildup. But patients with rheumatoid arthritis don't have this. They don't have high cholesterol. They don't have these aspects. So what happens is that they actually have what we call the lipid paradox, where they develop atherosclerosis, but don't have this high cholesterol. And that's something which we're trying to understand. What is the mechanism behind it? Why does that happen? Now, with the therapeutics now, we've seen a change in the incidence of atherosclerosis. And that's probably due to the overall inflammation in the body subsiding and being reduced. And that also contributes to atherosclerosis, meaning that the higher inflammatory state of the body, high inflammatory state of your tissues, that can also contribute to atherosclerosis. And that's why this is a systemic disease, meaning it's all over your body, but yet we see these target organs are being treated. Now, another thing to think about with rheumatoid arthritis is obesity. Patients who are obese have less response to therapeutics too. So there you're seeing that effect on obesity, on your metabolomics and metabolism, and how it deals with each therapeutic, yet it actually has a contraindication, meaning that it's not going to work as well. And again, why is that?
That's very interesting about the obesity comment and diet, because diet has played a huge role in, I've actually lost a lot of weight from when I was originally diagnosed to where I'm at today. And then of course on from there. So yeah, thank you for that. Dr. Lood, can mitochondrial cells be circulated despite normal CRP? What causes a treatment to lose efficiency over time?
So two very different questions, but we'll start with the first one. And the answer to that will be yes. Mitochondria can circulate despite normal CRP. Not always do they cause inflammation, and that's an area of research that we're trying to study, because this is a normal feature that happens also in healthy individuals. So it could occur and not cause damage. But we know in rheumatoid arthritis and in lupus, it does cause damage. And when it comes to CRP, it's a good marker, but not a perfect marker of inflammation. We know, for instance, in other diseases like lupus, they don't always have high CRP, but they still have inflammation, including driven by mitochondria. So certainly mitochondria can be out without causing CRP. When it comes to treatments losing efficacy, I think that's maybe a better question for Dr. Perlman or someone else, but I just give a quick try on it at least. One thing we do know is that some drugs, at least, where our immune system could sometimes develop a reaction towards drugs and produce antibodies, preventing the drugs from working. It is also so that our body is very adaptable. And sometimes if you block something for a long time, our body finds other ways to do the same thing, and that your drug doesn't work anymore. Those would be the two main things I can think of. I don't know, Dr. Perlman, if you have anything to add to that.
No, I think that's true. I mean, you think about it here, like I said, you have here potential, especially for the antibody mediated drugs. There's a chance that you can form an autoantibody against it. That's one of the contraindications. So patients who are treated with an anti-TNF, that's a humanized antibody, yes, there's, I think, 1 in 4,000 chance of you developing an autoantibody to that. And of course, the drug won't work anymore. So because what it does is the antibody targets the antibody, so now you don't have the correct way of working. And again, the body isn't amazing for its compensatory mechanisms. And I think that is exactly what Christian's saying there, is that you have this compensatory mechanism. So while it does work at point A, now things have changed. Now you need something that works at point B. I mean, of course, the greatest goal would be is to treat somebody in induce clinical remission and allow them not to even come back at all, to reduce therapeutics, to reduce steroids. I mean, that is the major goal of all this, to not put everyone on medicine. But, that's been the more difficult part.
All right, thank you for that. All right, next question. Either of you guys can answer this one. I love the biopsy approach. What are the next steps to categorize all the cells and the meds that they respond to? Yeah.
So I think, I'll take that one. Right now we have a study that's going on to any patient that's not been, who's failed the therapy, who hasn't been treated to therapy, to then have a biopsy. So the cellular characterization is something that it's ongoing. There's been a paper published by a large group of us in both in Nature, which is one of the top journals, talking about all the different cell types. Like I said, there's now 15 or 14 different macrophage populations. There are 27 different T cell populations and so on and so forth. It's really, again, this whole big complexity. And plus there's all these other non-immune populations that are heavily involved. The key thing is really patience, is having the right number, getting enough patients in your studies to be statistically significant. The more patients we can do before they change the therapeutics, more patients we can look at that are untreated, so early RA, and then are going to get a therapeutic, to have a biopsy. I mean, the issue comes up to be is that, you know, if you have your patient here coming in, kind of like Danny, what you guys, I don't feel like my body, everything aches, I can't move. So you come and get diagnosed, you have RA. And I think what scares, they say, oh, RA, can we do a biopsy right now? And that's, you know, like, wait a minute, I just heard I have a life-changing event right now. I have RA, which is a disease that's going to be with me the rest of my life. And you need a biopsy. Yeah. Wait, I'm sorry. I'm still like getting my head around it. And I think the key thing is us trying to like inform our patients through the Arthritis National Research Foundation, through their different ways of saying, okay, you've been diagnosed with RA. What's next? And it could be what next, how you're going to find your right physician, your right rheumatologist, the right person to help you, and what are the areas and the places that are doing research for you to be an active participant in the research, whether clinical trial, whatever research trial, and all these different parts.
Dr. Lood, do you have anything to add?
Sorry, no, I think that was a very good summary.
That's very good. All right, you guys, here's another one for either one of you. I've recently been diagnosed with RA. How do you get started on personalized medicine? Not sure if there's a kind of treatment in my area. How can I participate in research? So 3 different questions there.
Christian, why don't you go?
I can start from the bottom, I think. How can I participate in research? One way is really to speak to your provider, ask about what are the clinical trials ongoing? Is there any active research going on in your institution? And ask to participate in that if you in any way can do that. Another way is, of course, there are also these more national or international organizations, depending on your age and so forth. There is, in particular, I'm thinking about CARA, if you have a childhood arthritis. They would be very interested in following you. And so that would be a more like a global or national investigation. But really talking to your provider and asking if they have any active research, I think would be a good way. Treatment options, I'm not sure whether that should vary over the country. I'm sure there are some guidelines provided by both US and Europe on what treatments should be given and when, and if that fails, you go to a second tier and so forth. And there are good evidence, or as far as we can tell, good evidence for why you get certain medicines in certain times. So I'm just assuming that they will be able to give you that medicine, but again, that's a question for your provider to discuss. The personalized medicine is hopefully soon here, but not quite here yet. We're learning more and more about these different signatures that seem to identify patients with different disease severity and also who is going to respond better or not on certain treatments. And with the more and more advanced technologies, as you also heard from Dr. Perlman, we are getting closer to understanding that, but we just have to give it a little bit more time before we can have these FDA, if you would, approved biomarker panels.
Yeah, exactly. I think that's really well said. I think that with respect to therapeutic choices, a lot of, again, unfortunately, it does depend on insurance. You know, certain places you have to go through 1 or 2 types of therapies. Like the really most examples, if patients usually when they get diagnosed are going to go through a non-biologic first. And one example is methotrexate. So you're going to be put on methotrexate. There's going to be maybe there's only about a 25 to 30% chance it may work. And then afterwards, then insurance may allow to pay for a different biologic. And it's also preference of some different rheumatologists like different drugs. Again, like I said, you know, a lot of people start with the anti-TNFs because they came first. And it also depends on any other things that you might have within your system that they say, wait a minute here, you're not a candidate for this, or you're a better candidate for X, Y, and Z. And I think that, you know, it's just due to how the actual therapeutics works. You know, again, one is a therapeutic can be deplete your B cells. One can affect your T cell function. Another one can block your JAK inhibitor, your JAK pathways, which is again another immune pathway, another blocks TNF. So again, all those different aspects. And I think also to be involved, I think we have some major organizations. Again, Arthritis National Research Foundation can help steer you to groups who, if your area doesn't have a active research platform there. I think, one of the things that we're seeing in rheumatology in the country is while the cost of treating patients actually with rheumatoid arthritis exceeds patients with cardiovascular disease, yet we don't have as many people studying it. And the reason why is, we need support. I mean, it's an issue, again, at a chief's level here. So again, people will hire, and people like Christian, who I'd hire in my group, he's in Washington, but other groups I bring in here, it's trying to have them, get the support for them to do that next level, to do the research, to come into rheumatology. And, the places like Arthritis National Research Foundation, without their support, we wouldn't be able to. I mean, this is what we need, and we need the support from them to help train that next generation of rheumatology researchers who are going to want to pursue this career. And again, we are a shrinking group because it's just a tight field, and getting people more interested in research and getting more people interested in saying, we need to change how we treat patients. We need this help, and the help is through Arthritis National Research Foundation and your ability to work with us in trials.
All right, thank you so much, Dr. Perlman. All right, we got one more question, and this could be a loaded question, but we have like very few minutes here before we end our discussion today. So, with AI and other techie tests, will children benefit early in their lives to see if they will get RA down the road?
Just a quick comment on that. I think that the research is very strong. The earlier we can identify the disease and the earlier we can get patients into the remission, the better they are long-term, because they won't get all of these comorbidities and so forth. So certainly the earlier diagnosis, earlier treatment we can have, the better. And yes, with AI, we are going to do much better, I think. And we're also studying pre-RA, of course, before RA onset. Sorry, Dr. Perlman.
I think that for children, you want to separate yourself and think of children's associated diseases, especially with juvenile idiopathic arthritis and adult. A child that develops an onset of certain diseases, and it might be to a single gene mutation, might be due to something like that, versus an adult who develops it, or somebody even like who's 17, 18, who have multiple experiences in life, multiple ability, things that have affected their where they live, what they do, how they live, and all those different parts affect them with how their genes are being expressed. So it's what we call the environmental aspect. So that's something we can't always control. So I think for earlier children, yes, one of the things we are doing nowadays, I think more people are moving towards this, especially with AI and especially with the ability to sequence people, is that trying to understand early childhood arthritis by sequencing and finding out these specific mutations. And that will really also transform how we can do things.
All right, thank you so much. Okay, Emily, it's all yours, girl.
Thank you so much. And just a special thank you so much to our fantastic moderator, Danielle. We so appreciate you being here and sharing your story. Also, just thank you to our wonderful researchers for sharing their innovative work towards understanding RA. You can see firsthand the impact ANRF has in supporting these incredible individuals in their quest for a cure. I would also like to once again thank our corporate sponsor, AbbVie, for their support of this webinar. We'll be sending out a survey to our attendees, so please fill that out. Your feedback helps us find direction for future webinars. Please share your comments with us so that we can continue to provide important and relevant content to you. And please don't forget to sign up for our other upcoming Researcher Spotlight Series webinars. We'll be live at the same time on September 18th with psoriatic arthritis, October 2nd with scleroderma, October 16th with lupus, and finally October 30th with osteoarthritis. Lastly, just thank you to everyone who took the time to join the webinar today. It was a wonderful event. If you've enjoyed this webinar, we kindly ask you to consider making a donation today by visiting curearthritis.org/donate. Every contribution helps. Thank you all for coming, and please remember to follow us on social media as well to stay connected.